Comparing major gynecological surgery v mesh complication surgery. Are we achieving our ERAS protocol? Thank you for this opportunity to present on behalf of the urogynecology team based in the Queen Elizabeth University Hospital in Glasgow. We registered no conflicts of interest and no funding was sought in this audit. Enhanced recovery after surgery protocols were established in 1997 by Henrik Kellett in the field of colorectal surgery. Nowadays, these protocols are present in a wide range of surgical specialties, including gynecology. Henrik Kellett stated, changes in organ function, the so-called surgical stress response, are believed to be mediated by the trauma-induced endocrine metabolic changes. By minimizing this surgical stress response, patients mobilize and get better more quickly, and the overall length of stay in hospital reduces. The implementation of the ERAS pathway involved various changes in the preoperative, intraoperative, and postoperative care of the patients. In the preoperative stage, this included provision of ERAS information and fasting with carbohydrate drinks until 2 hours prior to surgery. In the postoperative period, the following ERAS key performance indicators were recorded: oral fluid intake within 4 hours post-op, mobilization within 8 hours post-op, IV fluid discontinuation within 12 hours post-op, and catheter removal by 7 a.m. day 1 post-op. Furthermore, the use of both regular and rescue antiemetics and analgesia was altered, along with the use of intrathecal morphine intraoperatively. Our audit had two aims. Our primary objective was to compare the compliance with the ERAS protocol, including the key performance indicators in the two groups: those undergoing major gynecological surgery, Group 1, and surgery for vaginal mesh complications, Group 2. Our second aim was to assess the difference in the use of regular and rescue analgesia and antiemetics in these two groups. We conducted a retrospective study identifying patients who underwent major gynecological surgery in the period of October 2020, which made up Group 1, and patients having mesh complication surgery in the year 2019 to 2020, comprising Group 2. Patient electronic medical records were reviewed, including the preoperative assessment, nursing records, and drug cardexes. There were 41 patients in Group 1 and 23 patients in Group 2, totaling 64 patients. When looking at the ERAS KPIs, we looked at the rate of compliance overall and then compared the two groups. The compliance rate for each of the KPIs for Group 1 and 2 can be seen in Figure 1. The drinking milestone was achieved 91% of the time and was comparable between the two groups. Only 22% of patients are recorded to have been mobilized within 8 hours of their surgery. However, 69% of patients' mobilization information wasn't recorded, so it's difficult to assess the true rate of compliance. IV fluids were stopped within 12 hours in 70% of patients. For 28% of the overall patient group, the reason for non-compliance wasn't documented. The removal of catheter milestone was achieved in 61% of patients. The three reasons for non-compliance were high levels of postoperative pain, being scared to move, or other postoperative complications. 17 patients were not eligible for catheter removal in accordance with the protocol, either due to surgeon's instruction or an intraoperative injury, and therefore they were not included in the statistic for this KPI. One patient didn't have a catheter inserted and so was also excluded from this KPI. Regular, long-lasting opioid analgesia in the form of Oxypro, Zumorph, Longtec, or a PCA was given to 70% of patients. Of the 19 patients who were not prescribed any long-lasting opioid analgesia, 89% required rescue analgesia in the form of morphine. When looking at the whole patient group, only 22% of patients were prescribed regular antiemetics. Of these patients, 86% required additional rescue antiemetics. Of the patients who were not prescribed any regular antiemetics, 82% required rescue antiemetics within the first 24 hours postoperatively. When comparing the two groups, they both had comparably low prescription rates of regular antiemetics, with Group 1 at 17% and Group 2 at 30%. Rescue antiemetic prescription was 14% higher in Group 1. When looking at prescription rates for analgesia, Group 2 had a 6% higher rate for prescription of regular analgesia, and there was no significant difference in the rate of rescue analgesia between Group 1 and 2. Some components of the ERAS protocol are being followed in a majority of women in both groups. There is currently discrepancy between surgeons on timing of catheter removal, and therefore a consensus on optimal timing needs to be reached. There are 3 main non-compliance issues: low rate of prescription of regular long-lasting opioid analgesia, low rate of regular antiemetic prescription, and non-documentation of various KPIs. Due to the high rate of rescue analgesia required, regular long-lasting opioid analgesia should be prescribed to all patients. Due to the high rate of rescue antiemetic prescription, it is clear that regular antiemetics should change from being discretionary to standard in the new ERAS protocol and at a higher dose. Addressing the non-documentation of certain KPIs will prevent perceived low compliance and allow for a more evidence-based analysis of such indicators in future audit cycles. The aim for the next cycle of this audit is to look at the effectiveness of the updated ERAS protocol, which will be revised following this cycle of the audit. In the next cycle, a larger number of mesh patients will need to be audited to obtain statistics for outliers in relation to pain in order to design a new ERAS analgesia pathway specifically for these patients. Thank you for your time, and I look forward to answering any questions.